Hello. I am Michael Luck. I am director of the King's Institute for Artificial Intelligence, and it is my pleasure to welcome you this evening to a talk from Professor Prokar Dasgupta, who will talk about the future of the digital future of surgery. Prokar is Professor of Surgery, Chair in Robotic Surgery and Urological Innovation. He is one of the world's leading experts on robotic surgery, and I'm delighted that he provides the complementarity to the last talk, if you were here and heard that, to make sure that we are covering the full range of implications of AI today. I won't say much more. Prokar, over to you.
Michael, thank you. As you can see, I am perfectly human and not a robot. The press would have you believe that a machine is just going wild and doing things, while I just sit there in the middle of the operating room drinking coffee. That is actually what the press made people believe. And 20 years ago, the public believed that. Someone actually said to me, really, why should I pay for your services? You just drink coffee, you program the machine. Nothing could be further from the truth. Let me show you where the future is going, because the future is very much now. The future is not what is going to happen in 20 years. The future is now, and you have been part of that future for the last 20 years. Remember, just before the pandemic, Jeremy Hunt, who is now the Chancellor of the Exchequer, said, let's schedule a review of what's going to happen to medicine in the next 20 years. So this is called the Topol Review. Topol is a cardiologist, a heart doctor, American, a thinker. And if you see the x-axis on top, it goes from 2020 on the left to 2040. See that? Yes? And then you see on the y-axis the technologies that are going to change the game, change how medicine is practiced. Some of you are carrying that technology today. Do you know that the smartest device is already in your pocket? Each one of you are carrying a mobile phone, aren't you? If you take it out, and let's do an experiment. Why don't you take out your mobile phones? Normally, Michael will say, look, switch off your phones, right? So let's have some love today, love. So just point it to your neighbor, get close, and take a selfie. Just do that. Just humor me, please. Look, you can humor me. Please, come on. I know you are the great professore, but take a photograph, a selfie. Yeah? Do you know what's happening right now? You've done that, yes? Your mobile is ferociously trying to think as to who is in that selfie beside you. Do you realize that? It's already doing that, even without you knowing. And if you had tagged that person, tomorrow morning it will tell you that these were the various times you were taking a selfie with this person this evening and 20 years ago in Paris, perhaps. That is the power of your mobile phone. Some of you went running this morning. You had your smart watch. Many of you are wearing them. Again, we give it to our patients to train and tell us whether they're getting fitter. AI is part of this. The most transformative surgery is part of this, robotic surgery. More about that in a minute. Can we write the genome today? Yes, we can. Can we actually change the genome? Can we take a single cell, take the code inside it, cut the bad parts of it? Say inside the cell is written, I really love you. And in a cancer cell, it changes to, I really hate you. Do we have the technology today, perhaps, where we can cut the hate and replace it with love? I put it to you that we have. It won the Nobel Prize for Chemistry. It's called CRISPR-Cas9. And it's the power of artificial intelligence which could potentially bring it all together with, of course, a note of warning. And the warning will come right at the end of this lecture. So you may say, what do you do for a living? Well, I'm a surgeon, as the introduction goes, but my main interest is in a gland that the men in this room have, called the prostate gland. Ladies, don't worry. You suffer with the men because your men wake up multiple times at night as they get older, about 50, to pee, and each time they wake you up. So women also suffer, but not with their prostates because they don't have it. The prostate is that red thing in the middle. It's a chestnut-sized gland. There's a man from the side. Above it is a bigger bag. See it? It's the bladder. Anyone fainting? I don't see anyone fainting. And then there's the water pipe. So the bladder has a water pipe which goes out into the penis. And then there are these amazing nerves behind the prostate. Very odd organ. It's here. And there are a number of things that happen to it. It's the size of a chestnut. But then it becomes this. It becomes the size of an apple. Yes? Chestnut, man turns 50. Not every man. In some men, it becomes the size of an apple. If it becomes the size of an apple, then the next thing that happens is that apple blocks the water passage. Yeah? See this? The water passage is going through the middle. If the gland becomes bigger like an apple, then it starts squeezing the water passage. When men can't pee, what we do is that operation on the top right-hand side. This was the bread and butter of surgeons like me. We put a telescope through the water pipe. Don't faint. That's what we do. You're asleep. And then we cut away the inside of the prostate like this, making a hole in the middle of the apple, cutting the core of an apple. You get it? Yes? This operation is called TURP. That's what it's called. And it's been around many years. And the first robotic surgeon in the world is my hero, John Wickham, the late John Wickham. He just didn't make it to 90. He was 89 when he passed away. And he said, well, let's design a robot with Imperial College. And that's the robot, that's from the BBC's archives, which can do this cutting the center of an apple, evaporating it in men where the prostate has become bigger. And he did this 30 years ago with a robot called the Prokar. Amazing, isn't it? So that is where this whole story of Mr. Wickham used to have coffee or wash his hands, press a button, and the machine would do the job, really came. So this was a true robot. It was completely and utterly automatic. And then last year, we celebrated the 20th anniversary, after 20 years, of the first trial in the world of robotics. This is a robot which removes kidney stones. What did we do? We put the robot at Guy's Hospital, and we controlled it all the way from Johns Hopkins in the United States. In those days, we used to use ISDN lines. Don't laugh. The lines are still there in the operating room, although they don't work. ISDN lines, high speed in those days. The machine could remove kidney stones slower, but much more accurately than a human being. So this is the first trial in the world showing that really we might be thinking of investing in robotics. We called it Star Trek, inspired by Star Trek, systematic, transatlantic, randomized tele-robotic access to the kidney. Impressed? But today, the operation where robotics has changed everything is in prostate cancer. So I told you the gland is here. Not only does it become big, it often gets a cancer. And there are many men who want that cancer removed. There are other ways of treating it, but there are many men who want the cancer removed. And the traditional way is on your left, where we make a big cut, blood, can't see, pack, can't see, get it out quickly, put some stitches. That's how we used to do it. Couldn't see anything. But we got the job done with our feel, etc., etc. We've changed the game. We now put 6 small holes in the tummy. We can see. we can see the prostate magnified at least 10 times. Beautiful. We can see in 3D HD, just like I'm seeing you, just like you're seeing me. And that is what we do today. And the machine is now 20 years old. It's the Rolls-Royce. It's been around a long time. It's manufactured by Intuitive, and it's called the Da Vinci robot after Leonardo da Vinci. But notice a number of things. The surgeon is sitting at a console. Their head is buried in something which looks like the bottom of an animal that you can imagine. I leave it to you. It used to look exactly like that. It's become more slick now. There is the patient underneath. There's a camera in the middle. There are these tiny little robotic arms. My glove size is 7.5. Can you believe it? The instruments are just 7 millimeters. It's like having my hands inside without making a big cut. And guess what? If I had Parkinson's disease, I might do, yep, the machine will just filter it. So even the tremor of the surgeon is filtered. Amazing. Amazing. Completely changed the game. I want you to look at the curve on the left. This is from the Royal College of Surgeons. This is now old. The new data has not been released. But in blue is the number in percentage of radical prostatectomies for cancer being done robotically. Even 5 years ago, it was 84%. When I started, it was 1%. In 20 years, we have completely changed how an operation is done. And today, I can tell you it's 94%. 94% of prostate cancer operations are done robotically. Game changed. But you may say, well, Prokar, you're a surgeon. Of course, you'll say, this is better than anything else. How do you know it's better than anything else? I just told you we did the world's first randomized trial. Yes? So let's put it to the test. Compare it against that big cut or keyhole surgery without a robot, because you can do keyhole surgery without a robot, just with chopsticks. Yeah? Okay. So the first trial was an Australian trial comparing prostate cancer removal, open versus robotic. The second trial is called Coral. It's my own trial. It's the biggest operation we do. Cystectomy. C stands for cystectomy. Bladder cancer operation. Lot of blood. Lot of complications. Open, robotic, and laparoscopic. That's why it's called Coral. You know, in UK, we love these acronyms. Every trial must have an acronym. Otherwise, the Lancet is not going to take it, I gather. So it's called Coral. And then you have others. You have Razor, 15 centers in the United States, open versus robotic, bladder cancer removal. And the latest one published, a British trial, which we were part of, called IROC, again looking at open versus robotic bladder cancer removal. What do the trials tell us? No difference. No difference. The outcomes depend on the expertise of the surgeon. Yes? If you put a monkey on the machine, the results will be like that of a monkey. You need the surgeon, whether open, keyhole, or robotic, to be experienced. Huge statement after spending millions and billions in this kind of technology. This was in one of the biggest journals in the world, the New England Journal of Medicine. Look at that. Billions in additional funding. Very worrying. So my first theme is, we can't continue doing this unless we look at the cost, because we can't afford it. But you could say, should we go back to this then? Should we all go back to open surgery? How many in this room, how many men would have an open radical prostatectomy based on what I have just said? Anybody? Any takers? I can't see any. And it's the public who voted for robotics, more than the surgeons trying to report their trials. It was the public drive that got us to where we are today. But there is good news. A group of us at King's, my own group, and a group at Harvard and Brigham, led by a very good friend of mine for 20 years, finally managed to dissect the data. And after 20 years, hand on heart, I can say that we did not sell off the NHS. For most cancers, whether it is of women, the bowel, or whether it's prostate cancer, robotic surgery is cost effective compared to open surgery. The out-of-pocket costs, i.e. what happens to the patient after they leave hospital? Do they get back to work quicker? Do they feel better? Do they have less blood transfusion because there's no blood? There's hardly any blood. The answer is yes, but it's taken us 20 years to assess the data and publish this paper. We have also done the same analysis last year for the NHS, and for prostate cancer, robotic surgery is as good as open surgery as far as cost is concerned. So I call this the Tesco effect. You go to Tesco, you look at various things, and you say, okay, here is a bag of crisps, £2.40. Tesco, if you have a Tesco card, £2.10. And then suddenly there is someone saying, hey, I'm going to sell it for £1.40. What do? You go for the £1.40. I do. This is part of the Tesco effect. And I must say that there are more players coming in the market. One of them is, I'm proud to say, a British robot. I have no conflicts, by the way, with any of these companies. It's called Vercius, manufactured by Cambridge Medical Robotics. You see, the surgeon does not have her head in a console. It's an open console. They're sitting in front of a computer. There is the robot, which has individual arms, much easier to move in, and the surgeon is staring at the screen by wearing 3D glasses. As these machines come into the market, the Tesco effect will take place, and that's precisely what's happening now. And we can practice, you can practice the operation before anyone else does. You're not just going to turn up and have a go, are you? You're going to practice. This is virtual reality. You can practice moving the instruments. You can practice the entire operation if you wish. And you can do this. This is the latest tech from CMR using virtual reality. Take a look at this. Virtual operating room. You're testing it. You're learning how to put the robotic arms in different places. Amazing. Impressed? Anyone not impressed? I'm pleased to say I have a gift for you. I need a volunteer. Georgina has come with this equipment. Who is going to volunteer to test this equipment? Come on. Come on up. What's your name? Keely? Edie. What do you do? Are you a surgeon, Edie?
I'm a student. I'm year 12.
Fantastic. Come on up. Give a round of applause to Edie, please. She is making sure that Edie does not fall over. Doesn't matter. Got it? Good. Can Edie see anything? Even when you have AI, the Wi-Fi does not work. Who the hell produces Wi-Fi at King's? Come on, we need to tell the principal something's wrong here. Right.
Okay, I think we are pretty much here.
Right, Edie, come on up. Okay.
Okay, so can you see on the screen yet?
No, not yet. Don't worry, but she can see.
No problem. So,
Yeah.
Edie, can you come and pop this headset on so that you will see the screen on there? Hope you don't mind your hair. Looking your
Wow. Oh.
This is the response we want.
Yes.
Okay, so
That's what she's seeing.
okay, so you don't have to see on the screen, but basically what Edie can see now is a virtual operating room. So she is actually standing within a theatre right now. How's it look? Yeah, pretty cool? Yeah, okay. Well, so you are obviously a person in the operating room, and I'm going to use some hands now. So this is your right hand, obviously, and come on to that, this is the left hand. So you are stood in one place right now in the operating room. I hope you don't mind me just touching you to get us where you need to be. But basically, you can teleport yourself throughout this operating room. So bear in mind, you've got quite a nice. Sorry, guys. Thank you. Can everyone hear me okay? Fab. So bear in mind, we've got quite a nice space here on the stage, but have a think about if you're in an office or a tight space and you still wanted to complete this training, you could do it within a very small area. So Edie, I'm now going to ask you to teleport within this theatre, okay? Yep. So the way that you're going to do that is use your thumbstick. So if I just direct your thumb to this stick here, and if you push forward on this thumbstick, just move your thumb a little bit closer. So can you feel it there? Can you grasp it there?
Yes.
Okay,
yeah,
so I want you to look at the floor, and once you push forward on this thumbstick.
push forward.
Yeah?
Yes.
Oh, yeah, I got it.
Okay, so you've now teleported over to this side. So if you spin yourself around, we can all see what's on the screen now.
Edie, you're not operating on my prostate, okay?
So I'm going to now ask you to
I
teleport.
will not allow it.
Just over to that blue circle there, okay? Yeah, that's it. That's where you want to be. So the system is now telling Edie some instructions about how she's going to start using the Vertius system. So can you hear that? Is it talking to you?
Yeah,
Okay.
Fantastic. Okay, Edie, thank you. Another round of applause for Edie. And let's move to the slides again, please. Thank you, Anna. Fantastic. Let's move back to the slides.
I know, it's mad, isn't it? Oh, sorry, thank you very much.
Okay, so the Tesco effect continues. The largest manufacturer in the world, Medtronic, again come up with an open system. And I can tell you, if you look online in different parts of the world, there are different systems. So the first message is the cost is going to come down because of what I've just told you. There are more players coming, and you can achieve the same keyhole operation by other technologies. But Intuitive Surgical, the brand leader, have said, well, while you do that, We won't make 6 holes. We'll make a single hole through the belly button. Yep. And the whole machine will come out like a flower. This is single port surgery. Why 6 holes? Why not 1 hole? So they are thinking even further, not yet available in the UK. We have Joydeep Sinha in the audience, orthopedic surgeon. You know? Bone and joints, I think I might need a hip replacement, Joydeep. Marathon running, hip aching. Can he get it better by a robot? Yes, he can, but the technology is too early to assess whether it will be truly better. And then you can take these amazing images and transport them inside the machine. This is an iPad called Translucent, whereby you can place it in front of the patient and you can literally look inside them. Yeah, there is the prostate. Yeah? There is the cancer. You can cut around the cancer. How amazing. It's just from an iPad. The technology exists today. And the next theme is then, with this kind of technology, should it just be in this room? Should it just be in the UK? Or should everyone have access to it? I put it to you that inequity is a problem which we have to deal with. And the answer to this is connectivity. Proximi is an augmented reality, mixed reality platform developed by Nadine Hakacharam, a plastic surgeon at Guy's and St. Thomas's. Amazing, look at this. This is a surgeon guiding another surgeon anywhere in the world. Amazing, changed the game during COVID of how to do a colonoscopy. And guess what? With all this intelligent data that has been gathered, say I am about to miss that tumor, the machine will tell us from its library, going back, just like I said to you, the selfie, it will tell us, hey, you're about to miss something, go back and have a look. And it's not just robotic surgery where Proximi has done well. Even in open surgery, look, in poor parts of the world, you can guide someone. Look there in colorectal surgery, and on the right is a story which featured in the Sunday Times, where my colleague, Archie Fernando, a famous robotic surgeon, was about to do a testis cancer operation in a young man. The only person with the expertise was in Seattle, a friend of mine, Jim Porter. So Jim sat in his pajamas at 2 o'clock in the morning, guiding Archie how to do the operation using Proximi. This happened during COVID. We didn't allow the virus to affect how we practiced and how we gave the best to our patients worldwide. Medtronic have something called digital surgery, where you can simulate operations, again, using artificial intelligence from the videos and the annotations that it gathers. And the final part of this connectivity is something that is in your mobile phones. We call it the Internet of Skills, and King specializes in this. Just imagine if I was trying to do an operation between London and Los Angeles. This would be virtually impossible unless we compress that signal, because otherwise I would move this, the machine will move 10 minutes later. The answer, we think, is 5G and possibly 6G. Imagine that glove on the left-hand side, which can feel inside a patient without making a single cut. It's called the neurodigital glove. And there is a little instrument, 3D printed, which is currently being manufactured by one of my readers all the way in Hong Kong, and then you splice it using 5G. We did the first such operation on Facebook Live in 2018, and the very next year, my Chinese colleagues published the first liver operation in the world using 5G technology. My final thoughts after cost and connectivity are about where we are going with AI. And you've heard a lot about this. Michael, I'm sorry to make it simple, but AI has to be for everyone. Imagine you're walking in a part of the world where you don't know what the notice says. What do? You take out your phone, you put it in front of this, and it says, danger, cliff ahead. So AI has to be for everyone. It just saved your life. I want you to think of AI and part of it, which is machine learning, as using data to answer questions. No one can make that simpler to you. Using data to answer questions. And in order to do that, there are 7 simple steps. First, you have to gather the data. Then you have to clean it up, because if you put garbage in, you'll get garbage out. Then you have to choose a model. For example, a model that can tell the difference between beer and wine by the color of bottles. Then you have to train that model with 80% of the data. So say you have 1,000 bottles of beer and wine mixed together, you have to train the model with 80%, and then you use it to see whether, like a little child, it has learned anything on 20% of the remaining data. It won't get everything right, then you tune it, which is called parameter tuning, and then you get an output prediction. Very simple, I know, but that's how I see the 7 steps of machine learning. This is something called neural nets, which you will be very interested in. Convoluted neural net, deep learning. All deep learning means is that there's an input, there's an output. The output does not recognize the input, but the signal goes back from the input to the output through hidden layers. If you have 2 or more hidden layers, it becomes deep learning. So that's what it does. It's like a brain which passes a signal from the left to the right, but unlike the brain, it can pass the signal the other way, and that is how the network works.
So anytime you're talking to your phone, it's pretty much a neural net doing that. It does really well in image recognition. Autonomous cars coming soon. The top flight method for genetic sequencing is a neural network. You can say they're loosely inspired by the brain. It is a network of neurons. People call it neurons. They're all connected to each other, going down through the layers. In a way, they mimic neurons in that they're little triggers. Each neuron has kind of a threshold called a weight where it makes a decision. So it takes in data, it could be a huge amount of images, and then once the network is trained, you can put one image in at the front. They fire when they see the thing that they want to see. So you get this kind of cascade moving through the neural network, and that does really poorly. It just does horribly. But there's this little magic trick called backpropagation, and this is very unbiological. Your neurons don't do this at all. But at the end, you're like, okay, well, you were wrong, but here's a proper picture of a dog. And now you send all that information back through.
So that's what I just explained to you. And the magic for us happens in a new lab. You're welcome to visit it. Please let me know. Don't just barge in, because no one will let you know. It's called Surgical and Interventional Engineering. It is bang opposite the Houses of Parliament in St. Thomas's, an amazing place where all this technology, the fastest supercomputer, comes together. One of the examples is called the Panda Challenge. 10,000 biopsies of prostate, the organ which I live with every day. You can train it so that it is as accurate as a pathologist reading what kind of cancer it is. It was called the Panda Challenge, which is why I have the image of a panda in the corner. You will remember it. Panda Challenge, a human being overtaken or almost as good as AI. This is Jiva AI from the National Clinical Entrepreneurship Program, can tell a cancer from a not cancer from a magnetic resonance imaging scan, 90% accuracy. And then you can take these scans, and the person who has done this is here. His name is Pankaj Chandak. You can volumize these scans so that you can get a 3D print. And I have here, a 3D print of a prostate. This is the actual 3D print of a patient's prostate with a cancer, all automatically generated just like that. The first such operation was on little Lucy, whose father donated a kidney. And Lucy was so small, Pankaj, that you had to design this by 3D printing to see where to put the kidney in. And then we have done the same with prostates to see if we can actually make the cancer operation more accurate. So here is a real-time experience with AI leading how surgical science is practiced. We have a trial, again, as I said. I'm a scientist. I don't accept this is right until it is proven to be better than standard of care. So I love this, but I'm not certain yet until the trial is done that this will be better than what we do today. The other thing you can do is take the video, put it in a black box, and there are certain movements that a surgeon makes that you can teach to the next generation of surgeons. Certain ways I move my needle driver, which makes it better, and this is called automated performance metrics. So the younger surgeons in the audience, there's hope. I think I can teach you better. And then automation returns. This is a robot that can suture better than a human being. So you could say, really, Prokar, time for you to retire. 20 years, long enough, become a burden. Time to go, a machine will take over. And here is where I think the most important message is. During COVID, Luke, Michael, I, many of us got a major grant called Trustworthy Autonomous Systems. Okay? The press got hold of it. They came to me and said, Prokar, surely with 30 million patients waiting, what you need to do is program 7 machines. Why are you just doing the operation? 7 machines doing the operation, 7 times the volume. This is the solution. I said to them, look, just because it can be done doesn't mean it should be done. The public may not trust it. I may not trust it. My patients may not trust it. And guess what? Every patient is slightly different. So I do not think that AI is going to replace us surgeons anytime soon, because you still need the judgment of a surgeon. And you, as the patient, some of you in the audience, need the judgment of a surgeon rather than a machine doing the job for you. So there are certain things the machine will do better, but not everything. This is called humanics. It's a science in itself. What are the things a machine can do better than a human being? But more importantly, what are we going to do for society better than a machine? Thank you so much. I am bang on time. I am not a late surgeon. Happy to take questions. Thank you.
Questions anywhere?
Thank you, that was marvellous. Please, could I understand a bit better why 5G and 6G is such a game changer?
It's because of a number of things. The latency is low. It is ultra fast. The human brain can deal with 10 milliseconds of delay. You can with 5G and 6G. 6G not yet ready, but we are working on it. You can reduce that latency even more. But you can also transmit the sense of touch, which you can't do. So you can't just not transmit the signal, you can also transmit the sense of touch, which was not hitherto possible on the traditional internet. Furthermore, I think it's cheap. There are concerns about 5G mass doing various things. We don't believe any of that is true. We believe that the potential is there. Of course, it needs to become cheaper and go beyond mobile phones. But I think 5G and 6G will improve the connectivity because of this low latency, ultra-fast transmission of signals.
I was wondering if there are any areas where it's currently very tricky to operate, where AI could come in and help, or robots could come in and help. And I'm thinking of new types of surgery, like operating on a fetus in the womb,
Yes.
which I understand is very tricky.
Yes.
Very high risk.
Yes, absolutely. So, in fact, in surgical and interventional engineering, my partner in crime is the head of biomedical engineering, Sebastian Orselin, and he has a major interest in doing precisely that. Has it become standard of care? Clearly not yet. The message I'm giving to you is yes, absolutely. In difficult to reach areas, even the prostate, clearly there is a role for the kind of surgery that I've shown you, to the point where 90% plus is being done like that. But the key is evaluation, and more evaluation, rather than saying, this is the tech, let's now find an indication for the tech, and let's tell the public this is really fantastic. And then in 20 years we have made our money, it doesn't matter whether it fails. So I think the key is we cannot keep spending money. We have fantastic tech. We have to make sure that it is value-based. We have to use it for indications, like you said, fetal surgery. But at the same time, if I was a surgeon and a scientist, I would want to see that evaluation data which the public can trust.
I want to ask you a question about one of the challenges that you've just talked about, trust between patients and, well, exposing themselves to robotic surgery.
Yes.
How can you, what do you see as maybe solutions to this problem? How can the trust be established?
It's a very complex question. I have a BSc student who is currently looking at this. She's a medical student but has an interest in sociology, so she's guided by a social scientist, trying to see through interviews whether she can deliver and develop themes of trust. One of the things that I didn't tell you, because this is a public lecture, is there are machines. There is a machine certainly which has taken Wickham's concept and used a water jet to make a hole in the middle of the prostate in a semi-autonomous fashion. So you program it, you press a button, and it does the job with a water jet. Yeah? So we are going back to the Wickham days in some ways. We have found that interviewing surgeons who are using the Da Vinci system, interviewing patients, interviewing the teams, that by and large there is trustworthiness. Otherwise we wouldn't get to this point. There is trust in these machines as long as there's a human being at the end of it. Yep. What we don't know is whether, going back to the John Wickham days, as to whether the public will trust more and more automation. Yep. So that question remains unanswered. We are working on it. Hopefully in a couple of years we will have developed the right themes to see if the public really trusts it.
Hey Prof, how you doing? Thanks
evening.
for the amazing talk. Something I was going to ask about is, I found it really interesting, the role of the patient when moving towards robotic surgery.
Yes.
What is the role of patient? How does the role of the patient evolve when we're moving towards machine learning and AI?
Yeah. The answer is more of meetings like this. I don't think we are doing enough to engage with the public. We must do more. I certainly do not, on the consent form that I take from every patient, say we are using more artificial intelligence, because that would take an entire week to get their consent. So the patients get an understanding. They are not foolish. They are suffering, and the modern patient, of course, knows more than me because they have read up everything that is there to read up, and they ask clever questions. That's what the modern patient is. So the patients are not silly. They know what they are coming in for. What we need to do as the technology evolves is to educate them more about humanics, make it simple for them. There is so much about ChatGPT and more about the ethics. And you may say it's just Elon Musk ranting around. It's not. There is some truth to this. And unless we get it right for society, I think we would have done them a great disservice. I wonder what I would do if I became a patient, which I will one day. I will do what everyone does. I will look at Dr. Google. My chiefs used to say, oh, the patients come up with sheets of paper from Google. My God, I tell them, go away. I welcome it. So they look at Dr. Google. They will come along. Some of the information will be wrong. It's my job and our job to then correct that information so that we can educate them and work with them to come to the right decision. So a lot of work to do, my friend. We are not there yet. A lot of work to do.
Just on some of your examples where you were looking at VR and augmented reality and training surgeons across different countries.
Yes.
Where you've got an operation that might allude to clinicians making potentially decisions and potentially sharing decision making.
Yes.
How do you ensure that the technology also considers accountability of clinicians within that process?
It doesn't, is the answer. The clinician is very much reliant on the technology. What the technologists are now realizing is that not involving the surgeon in that developing tool is a mistake. Previously, what happened was there was a lot of interest in tech. 20 years ago, that's what happened. Let's bring in more tech, more tech, more tech. And then suddenly you'd find that half of them just disappeared, more than half. Why? Because then they were trying to find a reason for the tech to exist. Today, the tech companies have become wiser. They are bringing the clinician in and asking them, what is the unmet need? Let's try to fix it. Again, a lot of work to do, because rather than fit the tech to the disease, it should be finding the need for the tech, not developing it, wasting money, and then find that we have to figure out what to do with it. So that's changing. It's not changed, but it's changing. I've come up so that you can see me better and I can see you better. I want to feel you, man. Yes.
What does your research suggest about the issue of responsibility? So what if something goes wrong? So who takes the responsibility? Would it be the surgeon or the designers who have designed the machine? And since autonomous is here very obvious, so are we looking for some new regulatory regime?
Two answers to it. The first simple answer is the surgeon is responsible, not the technology. This is not Volvo saying that our AI is so good that we are responsible if the car crashes. I'm responsible when a complication happens to my patients, and I remember my complications more than the great work that I've done. And I can tell you, the surgeons in this room, all of them will tell you that they are responsible and they remember their complications more than anything else. The second part is you will hear an announcement next week. It is embargoed, which I can't tell you, but there is an entire funded program from UKRI precisely on responsibility in artificial intelligence. I don't think I can tell you more. I'm not allowed to. I'm part of it. It ends there. So it's a 5-year program. I'm not allowed to. Lips are zipped. Surgeons usually blurt things out, but I'll be killed. Yeah? My prostate will be taken out before next week without anesthesia.
Thank you so much for the talk. So clearly with prostate surgery, there was a drive in quite well-resourced settings because of the unacceptable side effects of impotency, incontinence.
Yes.
And there was a niche to be filled.
Yes.
I love the idea of the remote operating either by experts in centres who are able to share their expertise to other parts of the world.
Yes.
And I wonder what you think the future of that is in terms of, for example, having somewhere in the third world or the developing world where you could port out a robotic surgeon that could be controlled from other centres of the country. Do you think that's on the cards? Because with appendectomies, for example,
yes,
there's no terrible side effect profile to drive well-resourced parts of the world to change to robotic surgery. It would purely be to provide remote access of operations.
I think the tech exists today, as you know. What I've shown you is tech that is today. It's not future. When we launched Versius, the surgeon who was due to guide me, he hadn't done a prostatectomy, but he had used the CMR. He was in Italy. COVID was rampant. So he connected with Proximy, and I was all kitted out with this. And he was looking at my hands. He didn't know how to do a prostate. No one did. But I did. But I needed someone to guide me how to move the new tool. I had practiced, of course, a long, long time. So that is there in real time. It can happen. And I think that is the real need. Today, if someone from, say, north of Scotland says, look, we have a new machine, will you please travel? I say, look, I could, and I could have a coffee with you, but it's much easier for me to connect from my office, and I'll give you the same service, if that is acceptable to you. The other part, and you can use that tech, you can use Proximy-like tech, there are others as well, where even in poorer parts of the world, and in fact, initially it was done in poorer parts of the world, you can transfer the skill by training the younger surgeons, the less experienced surgeons, with that technology. The technology also exists to do real time. As I showed you, Star Trek is 20 years old, 20th anniversary. So the tech existed. The problem then is something called LC, ethical, legal, and societal issues, whereby even within the United States, you cannot operate remotely from one state to another because the laws are different. So I think what will bite in are ethical issues, legal issues, because the laws will be different, and societal and cost issues. I think the cost has come down, so it will mainly be ethical and legal. And you might say, is it really worth it? Why should I spend a year trying to fix my indemnity when I could just jump on a cheap flight and get there spending £5? So I think a lot of work to do even in remote areas.
I'm sorry, I'm gonna have to say we are out of time. I would like to say that I agree with Prokar absolutely that events like this are really important for addressing the questions that we need to face right now, and that there is a real public education need. What an amazing talk from Prokar Dasgupta. Please join me in thanking him. I have one thing to say, which is, as you leave the building, you have to use level 1 rather than level 0, because level 0 will be closed. Please join us for the remaining 3 days of the King's Festival of AI. I don't know if we can follow Prokar's example, but there will still be much more exciting content to come. Thank you all.